risk factors and different diseases and conditions that you will see during pregnancy. So first is abortion. So abortion is defined as a pregnancy that ends before 20 weeks gestation. This can be either spontaneously or electively. And in the realm of abortion, this also includes miscarriages. So you can see your risk factors there: advanced maternal age, any previous abortions or miscarriages, mothers with celiac disease, PCOS, or thyroid dysfunction, or those with a low BMI are also at an increased risk. Any mother who goes through an abortion, whether it's elective or it's a miscarriage, they will have a lot of spontaneous bleeding. So as the nurse, it's very important to count their perineal pads to evaluate for blood loss. And you're going to want to save any expelled tissues or clots and show those to the physician. Also, always remember that you're going to give the Rh immunoglobulin to an Rh negative women. So insulin needs during pregnancy. Maternal glucose crosses the placenta, but insulin does not. So the fetus pulls glucose from the mother and it produces its own insulin, which predisposes the mother to hypoglycemic episodes. Okay, so the mother is going to be pre-exposed to hypoglycemia. During the first trimester, maternal insulin needs decrease, while during the second and third trimester, there is an increase in placental hormones that cause an insulin-resistant state, requiring an increase in the mother's insulin dose. So the mother is going to be at risk for hypoglycemia primarily during that first trimester of pregnancy. All right, gestational diabetes. So screening for gestational diabetes occurs between 24 and 28 weeks of gestation. So first, the mother will complete a 1-hour glucose test. If that is abnormal, then they will move forward to complete a 3-hour glucose test. And that 3-hour glucose test is used to confirm the diagnosis of gestational diabetes. So risk factors include a mother that's older than 35 years of age, one that is obese or has a history of PCOS. The use of steroids can obviously cause elevated sugar levels. And then a previous delivery of a fetus weighing greater than 9 pounds is also a risk factor. So as we mentioned, there's an increased incidence for gestational diabetes in patients with PCOS. Gestational diabetes may be treated with diet alone. However, some mothers will require insulin. And then it's important to know that mothers that develop gestational diabetes, they should return to a normal state after birth, but it does put them at an increased risk for developing diabetes at some point in their lifetime. Assessment findings for a patient with gestational diabetes. This mother is going to have excessive thirst or hunger. They may experience weight loss, frequent urination, recurrent UTIs and vaginal yeast infections. They may also have glycosuria and ketonuria, some presence of ketones in the urine. They may have a large for gestational age fetus. And then they also may be diagnosed with polyhydramnios, which is the excessive accumulation of amniotic fluid. So interventions, you're going to instruct this mother on the importance of checking her blood glucose 4 times daily. So 4 times daily fasting. And 1 to 2 hours after meals. So a fasting glucose, the target should be less than 95. 1 hour after eating, the target glucose should be less than 130 to 140. And then 2 hours after eating, the glucose should be less than 120. You want to continually assess this mother for any signs of preeclampsia, which is characterized by hypertension. And the mother with gestational diabetes are going to have visits every 3 weeks until 36 weeks gestation, and then they're going to have visits weekly. For this mother, postpartum, it's very important to monitor the mother for hypoglycemia because there's a decline in insulin requirements that normally occur within the first 24 hours after giving birth. So DIC, or disseminated intravascular coagulation. So this is a maternal condition in which the clotting cascade is activated, resulting in the formation of clots in the microcirculation. So there is a rapid, extensive formation of clots that occurs in DIC. This causes platelets and clotting factors to be depleted, which results in bleeding and the potential for vascular occlusion of organs from blood clot formation. So there are certain conditions that can predispose a mother to an increased risk for DIC. Those include placental abruption and amniotic fluid embolism, those with gestational hypertension or any hypertensive disorders of pregnancy, and those with liver disease as well. So assessment findings for DIC, of course, they're going to have uncontrolled bleeding. You're going to see bruising, the presence of occult blood and secretions, hematuria or vaginal bleeding. They're going to have decreased fibrinogen levels, decreased platelet count, and decreased hematocrit levels. And they're going to have increased PT, clotting time, and fibrin degradation products. Renal failure is a potential complication of DIC. So in a patient at an increased risk or suffering with DIC, you want to monitor for adequate urine output, which is at least 30 mLs per hour. And then you're always going to monitor for signs of shock as well. All right, so an ectopic pregnancy is not a viable pregnancy. So when the implantation of the fertilized ovum is outside of the uterine cavity. So this mother they're going to have a missed menstrual period. They're also going to present with abdominal pain, vaginal spotting, and then rupture of that ectopic pregnancy will be characterized by increased pain, referred shoulder pain, and signs of shock. So in a patient diagnosed with an ectopic pregnancy, methotrexate may be given to help to inhibit cell division in the developing embryo to keep it from getting any larger. And then also the Rh immunoglobulin is always going to be prescribed for Rh negative mothers. All right, so hepatitis B infection, very important to know for the NCLEX. So of course, Hep B is transmitted via body fluids. So this includes vaginal secretions, breast milk, and it can cross the placental barrier. So for a mother with Hep B, there's an increased risk for prematurity of the baby, low birth weight, and even death of the neonate. You do want to support breastfeeding after neonatal treatment for hepatitis B. So important to know that breastfeeding is not contraindicated if the baby has been vaccinated. So interventions, very important to know your interventions for Hep B infection. You want to limit the number of vaginal exams to decrease risk of intrapartum ascending infections. You want to remove maternal blood immediately from the neonate after birth. You want to suction all fluids immediately after birth from the neonate. You're going to want to bathe the neonate before any invasive procedures. This includes injections. So make sure you're bathing them, getting all the secretions off before you do anything invasive. That includes injections. And also, you're going to administer the Hep B vaccine, but only after the infant has been bathed. Of course, the second dose of that Hep B vaccine would be given at 1 month, and then the third dose would be given at 6 months. All right, so HIV and AIDS, of course, a 3-drug combination of highly active antiretroviral therapy is recommended to try to reduce mother-to-child transmission. It is important to recognize zidovudine as a prevention treatment for mother-to-child transmission. So zidovudine is given orally to the mother at 12 weeks gestation. Then it's given IV during labor. It's given IV 1 hour before vaginal birth and 3 hours before cesarean birth. And then it's given in the form of a syrup to the newborn 2 hours after birth, and then every 12 hours for 6 weeks. So be able to recognize zidovudine as the treatment for mother-to-child transmission of HIV and AIDS. So this mother is, of course, going to be monitored by an infectious disease specialist. She is managed as high risk due to she may be immunocompromised and have a high risk for infection. A vaginal birth is acceptable for the mother with HIV if the viral load is less than 1,000. However, if the viral load is greater than 1,000, a C-section is recommended. The newborn may need to be placed in the NICU to begin the zidovudine therapy. And in diagnosing HIV, of course, ELISA is the screening test. If that's positive, and Western blot test is completed, which is confirmatory. A positive ELISA that fails to be confirmed should not be considered negative, but then it should be repeated in 3 to 6 months. All right, so interventions, like we said, in that prenatal period, you want to avoid any procedures that increase the risk of perinatal transmission. So this includes scalp sampling or an amniocentesis. In that intrapartum phase, you're going to avoid the use of oxytocin. So oxytocin can cause the contractions to be very strong, which could potentially lead to vaginal tears, which could lead to an episiotomy, which you want to avoid. So avoid the use of oxytocin. You're going to wash or remove fluids from the newborn promptly, and then of course you're going to give the zidovudine as prescribed. In that postpartum period, breastfeeding is likely to be restricted, and the newborn will be placed in the NICU for the first 24 hours to begin the zidovudine treatment. All right, so a hydatidiform mole, also a non-viable pregnancy. So it's a form of gestational trophoblastic disease that occurs when the trophoblasts develop abnormally. So the trophoblasts are the peripheral cells that attach the fertilized ovum to the uterine wall. So when those develop abnormally, you get what's called a hydatidiform mole. So the mole appears as a grape-like cluster that may be non-malignant or may develop into a choriocarcinoma. So of course, the fetal heart rate is not going to be detected. The fundal height is going to be greater than expected. The mother is going to have elevated HCG levels, and then you will see what's called a snowstorm pattern on the ultrasound, and they may also suffer with vaginal bleeding. So evacuation of the mole is usually done by vacuum aspiration. The tissue is then sent to the lab. Follow-up in patients with a hydatidiform mole is very important because you want to detect for changes that may be suggestive of malignancy. So the HCG levels are monitored every 1 to 2 weeks until pre-pregnancy normal levels are obtained, and then the levels are continuously checked every 1 to 2 months for 1 year after that. Now, HELLP syndrome, it's a type of hypertensive disorder of pregnancy. So it stands for hemolysis, elevated liver enzymes, and a low platelet count. So RBCs are damaged or destroyed, the blood clotting is impaired, and the liver can bleed internally, which can cause chest or abdominal pain. So this is a medical emergency. Preeclampsia is also a type of hypertensive disorder in pregnancy. So a pregnant mother with hypertension, that hypertension can lead to preeclampsia, which can then lead to a worsened case of eclampsia. So with preeclampsia, the mother is going to have persistent hypertension, swelling of the face or hands. They may have a headache, changes in eyesight. Just think, what are the symptoms of hypertension? That's what this mother is going to have. Risk factors for the development of preeclampsia is a mother older than 40 years of age, either a family or a personal history of preeclampsia. African Americans are at an increased risk. And then women who have underwent in vitro fertilization are also at an increased risk for preeclampsia. But I want you to associate preeclampsia with hypertension. Now, diagnostics is a blood pressure greater than or equal to 140/90 on 2 occasions, at least 4 hours apart, after 20 weeks gestation in a woman with a previously normal BP. So in preeclampsia with severe features, the BP is going to be greater than or equal to 160/110. The mother may suffer with hyperreflexia. They may have an elevated creatinine and liver enzymes, and then be oliguric as well. So proteinuria used to be used as a diagnostic measure for preeclampsia, but it is no longer used. So go by the blood pressure for diagnostics. So interventions. Early delivery may be recommended at about 37 weeks gestation. They're going to have weekly or twice weekly healthcare visits. You're going to want to encourage lateral or side lying positioning for this mother. Also, due to the likelihood of an early delivery, corticosteroids may be prescribed to help to promote fetal lung maturity. And then magnesium sulfate may be prescribed to prevent seizures or the development of eclampsia. So remember, anytime you're dealing with magnesium sulfate, be able to recognize the signs of magnesium toxicity. These include decreased deep tendon reflexes, decreased urine output, sweating, flushing, hypotension, and know that your antidote for magnesium toxicity is calcium gluconate. A complication of preeclampsia is DIC, okay? So eclampsia. So eclampsia is the progression of preeclampsia. Eclampsia is characterized by the presence of seizures. So these seizures in a pregnant mother are usually going to begin with twitching around the mouth. The body is then going to become rigid. The muscles are going to contract and relax in rapid cessation. Your respirations may cease during the seizure, and then the mother is going to go into a postictal sleep, just as you would with a normal seizure. When a mother with eclampsia has a seizure, you're going to want to place oxygen at 8 to 10 liters. All right, placenta previa. Placenta previa is an improperly implanted placenta in the lower uterine segment near or over the internal cervical os. So you have a total, partial, and marginal types. Total placenta previa is when the placenta completely covers the internal cervical os. Partial is where the lower border is within 3 centimeters of the cervical os but does not fully cover it. And then marginal is when the placenta is implanted into the lower uterus, but its lower border is greater than 3 centimeters from the internal os. Now, certainly know the difference between placenta previa and placental abruption, which we'll go over next. Placenta previa is characteristics of painless is going to be key, painless bright red vaginal bleeding. The uterus is going to be very soft, relaxed, and non-tender. And the fundal height may be more than expected for gestational age. So diagnosis of placenta previa is confirmed via ultrasound. It's usually diagnosed about halfway through pregnancy. And then vaginal exams are going to be contraindicated for this patient. Again, with placenta previa, you're going to have painless, bright red vaginal bleeding. The uterus is going to be very soft and relaxed. Now, with placental abruption, this is the premature separation of the placenta from the uterine wall after the 20th week of gestation and before the fetus is delivered. This is going to be characteristic of painful dark red vaginal bleeding. So they're going to suffer with uterine pain, uterine tenderness, uterine rigidity, accompanied with abdominal pain. So and depending on where the separation is, there may be an absence of bleeding, but know the difference that placental abruption is going to be very painful, whereas placenta previa is painless. All right, tuberculosis. So transplacental transmission of tuberculosis is very rare. However, transmission may occur through birth or may occur during birth through the aspiration of infected amniotic fluid. So if tuberculosis is suspected in a mother, an x-ray is not done until after 20 weeks gestation, and then of course the lead shield needs to be utilized to cover the abdomen. So of course normal transmission of tuberculosis occurs via airborne. Active tuberculosis during pregnancy has been associated with an increase in hypertensive disorders of pregnancy. That's your HELP syndrome, your preeclampsia, your eclampsia, and your DIC. Also know that TB skin testing is safe during pregnancy. So intervention, so the pregnant mother is going to receive therapy daily for 9 months. Know that pyridoxine can be administered with isoniazid to the pregnant patient to prevent fetal neurotoxicity that can be caused by the isoniazid. And then you want to promote breastfeeding only if the mother is non-infectious. If the mother's sputum is free of organisms, the newborn does not need to be separated from the mother while in the hospital. Now, with the newborn, they're going to be tested for TB at birth, and then that testing is going to be repeated in 3 to 4 months. They will also start isoniazid therapy at birth. It may be stopped in 3 to 4 months if testing is negative. If that testing is positive at birth, the newborn will receive about a 6-month course of the isoniazid. All right, so obesity in pregnancy, obese mothers, they're going to suffer with an increased risk for gestational diabetes, gestational hypertension, preeclampsia, the development of clots, and the increased need for a C-section. There's also going to be an increased risk for stillbirth, premature birth, future obesity, heart disease, and then they also may suffer with breastfeeding difficulties. So, obese women, they are going to have a lower prolactin response to sucking in the first week postpartum, which can lead to that breastfeeding failure.